morning. My name is Hannah Shepard, and I'm a CST Applied Epidemiology Fellow at the Massachusetts Department of Public Health Center for Birth Defects Research and Prevention. And today I'll be presenting characteristics of people with and without laboratory-confirmed SARS CoV-2 infection during pregnancy in Massachusetts from March 2020 to March 2021 on behalf of myself and the rest of my study team, including Dr. Masa Yazdi, Dr. Susan Manning, and Dr. Irini Nestoridi. So just to give a brief overview of what I'll be presenting today, first I'll provide some background on COVID-19 surveillance among pregnant people conducted in our state that's part of a larger CDC surveillance project. Then I'll discuss the methods we use to compare characteristics of people with and without SARS CoV-2 infection during pregnancy. Next, I'll present our descriptive results. Then I'll move on to the conclusions and limitations of this work, and then I'll close by discussing some public health implications. So to give a bit of background about the larger CDC surveillance project that our COVID-19 surveillance contributes to, which is called the Surveillance for Emerging Threats to Mothers and Babies Network, or SETNet. So in response to the Zika virus outbreak, CDC established a mother-baby linked longitudinal surveillance approach to monitor the impacts of the Zika virus on pregnant people and their infants. And then in 2019, this surveillance approach was adapted for syphilis and hepatitis C. With the onset of the COVID-19 pandemic, SETNet was further adapted to monitor the impacts of COVID-19 on pregnant people and their infants. And here's a map of all the jurisdictions currently contributing data to SETNet. There are currently 31 jurisdictions participating, including Massachusetts. So in Massachusetts, we began participating in SETNet in August of 2019, and initially we focused on hepatitis C, and these efforts were led by the Bureau of Infectious Diseases and Laboratory Sciences, or BIDLS. In April of 2020, we added COVID-19 surveillance to SETNet, and these efforts were led by our Center for Birth Defects Research and Prevention. Because of the work that was done during the Zika response, we were really well poised to take on this COVID-19 surveillance project since we had established partnerships with BIDLS. The goal of SETNet is to better understand the impacts of emerging infections on pregnant people and their infants. And the data elements that we gather emphasize maternal, birth, and infant outcomes, including things like clinical course of disease, timing of SARS CoV-2 infection in relation to pregnancy, underlying risk factors, adverse fetal and birth outcomes, as well as frequency and risk factors of neonates who test positive for COVID. So using our Massachusetts SETNet data, we investigated two study questions. First, we sought to compare characteristics of pregnant people with and without lab-confirmed SARS CoV-2 infection during pregnancy in Massachusetts. And second, examine the independent effect of race ethnicity as a proxy for other unmeasured social, environmental, or structural factors on the risk of SARS CoV-2 infection during pregnancy. So now a bit about our methods. This is the human infection with 2019 novel coronavirus case report form that is completed for all COVID-19 cases. And here you can see the checkbox on the form to indicate pregnancy. Unfortunately, we discovered a great deal of missingness for this field, and as a result have instead relied upon data linkages with vital records to identify pregnant people with completed pregnancies. So an overview of this linkage process. First, we start with a list of females of reproductive age, which we broadly define as age 11 to 59, who have lab-confirmed SARS CoV-2 infection, which gets exported from the Massachusetts Virtual Epidemiologic Network, or MAVEN. We then link this line list to vital records data using deterministic and probabilistic data linkages with birth certificates and fetal death records to identify pregnancies. And then those who match to a vital record are then further examined to see whether their positive COVID test fell within their pregnancy window. And if so, they meet SETNet criteria, and we import both mom and baby's data into our REDCap database. So for this study period of March 1st, 2020 through March 31st, 2021, we restricted to live births, and there were 69,960 live births in Massachusetts. And of these live births, 3,119, or 4.5% of the sample, were born to people who were SARS CoV-2 positive during pregnancy. And the remaining 95.5% were considered to be SARS CoV-2 negative during pregnancy. However, since we were unable to obtain reports for negative SARS CoV-2 tests, we consider those who did not link to a positive SARS CoV-2 case report during the same calendar time, or who linked but the test was outside the pregnancy window, to be SARS CoV-2 negative during pregnancy. So for our study, we compared the following characteristics of pregnant people by their SARS-CoV-2 infection status. These included demographic characteristics, including age, race, ethnicity, spoken language, education level, nativity, and insurance at delivery, as well as comorbidities such as pre-pregnancy diabetes and hypertension, adequacy of prenatal care, and pregnancy complications such as gestational hypertension and diabetes. And for our analysis, we first used chi-squared tests to compare distributions of the characteristics of pregnant people by their SARS-CoV-2 infection status during pregnancy overall, and then stratified by race ethnicity. And then we did some modeling using modified Poisson regression to calculate crude and adjusted risk ratios. And the data analyses and linkage process we described were all conducted using SAS version 9.4. So now I'll move on to our results. We'll first present the characteristics for which statistically significant differences by SARS-CoV-2 infection status were observed, and then we will describe results from our multivariate analysis. So here's a breakdown of maternal race ethnicity by SARS-CoV-2 infection status during pregnancy. Race ethnicity was self-reported and obtained from the birth certificate. Here in the figure, the orange bars represent people with SARS-CoV-2 infection during pregnancy, and the blue bars represent those who were not infected during pregnancy. So the orange bars all sum to 100%, as do the blue bars. So among COVID-positive pregnant people, we see that almost half are Hispanic, compared with just 20% of the COVID-negative group. And we also see that non-Hispanic Black people are disproportionately COVID-positive when compared to the COVID-negative group. Non-Hispanic white pregnant people, however, were more often SARS-CoV-2 negative during pregnancy. And when we look at age, we see that higher proportions of SARS-CoV-2 positive pregnant people were younger, more often falling into the less than 20, 20 to 24, and 25 to 29 age ranges, and that higher proportions of SARS-CoV-2 negative pregnant people were older, with about the same proportion of people falling into the over 40 years old category. This is now broken down by education level, and we see that higher proportions of SARS-CoV-2 positive pregnant people had fewer years of education. So while around 30% of those who were COVID positive had a high school education or less, just around 23% of COVID negative pregnant people had this level of education. And while 26.8% of SARS-CoV-2 positive pregnant people had a bachelor's education or higher, nearly double the proportion of SARS-CoV-2 negative pregnant people had this level of education. And when we look at preferred spoken language, COVID-positive pregnant people more often preferred to speak languages other than English, especially Spanish, when compared to the COVID-negative pregnant folks. And then looking at nativity, we see that over 50% of COVID-positive pregnant people were born outside of the US, which is nearly double the proportion of people born outside of the US who were COVID-negative. And we wanted to capture this given that immigration status has been known to drive health inequities that are being reflected during this pandemic. And we also wanted to have a more nuanced and intersectional understanding of the demographic differences by COVID-19 infection status. And looking at insurance, here we see higher proportions of COVID-19 positive pregnant people had Medicaid compared to the COVID-19 negative group. So clear racial and ethnic inequities and many other socioeconomic inequities during this pandemic that are impacting pregnant people. And when we looked at adequacy of prenatal care, which was operationalized using the Cottle-Check Index, which is a composite of two factors, including timing of initiation of prenatal care and volume of prenatal care visits, we saw that slightly higher proportions of COVID-positive pregnant people had inadequate prenatal care and slightly fewer had adequate prenatal care. So in our multivariate analyses, we looked at the adjusted and unadjusted risk ratios for SARS-CoV-2 infection during pregnancy by race ethnicity. So we see in our crude model that Hispanic pregnant people are 3.6 times more likely to have COVID-19 during pregnancy compared to non-Hispanic white pregnant people, our referent or comparison group. And non-Hispanic Black pregnant people are 2.7 times as likely than non-Hispanic white individuals to have COVID during pregnancy. In our multivariate analysis, trying to examine the independent association between race ethnicity and COVID-19, this elevated risk among Hispanic and non-Hispanic Black pregnant people remains, with Hispanic pregnant people having twice the risk of COVID during pregnancy and non-Hispanic Black pregnant people having 1.9 times the risk of COVID during pregnancy, when we adjusted for sociodemographic characteristics, pre-pregnancy conditions, and pregnancy complications in our fully adjusted model. However, we really want to emphasize that we know that race is a social construct that does not biologically predispose certain groups to SARS-CoV-2 infection, so we understand race ethnicity in our analysis as a proxy for other social, environmental, and structural factors that we cannot measure with the data available in this analysis, especially systemic racism, that's driving the observed association between race ethnicity and risk for COVID during pregnancy. So we identified a disproportionate impact of COVID-19 on Hispanic and non-Hispanic Black pregnant people in Massachusetts, and we also observed differences in sociodemographic characteristics by SARS-CoV-2 infection status during pregnancy. Pregnant people with fewer years of education, who preferred speaking a language other than English, who were born outside of the US, had public insurance, and who had less adequate prenatal care were also disproportionately impacted by COVID-19. The intersection between these social determinants of health and systemic racism may further worsen maternal and child health inequities. Moreover, we saw that Hispanic and non-Hispanic Black pregnant people had elevated risk of SARS-CoV-2 infection during pregnancy after adjusting for all sociodemographic characteristics in our model, highlighting other unmeasured factors associated with race ethnicity such as discrimination and structural racism that confer excess risk for SARS-CoV-2 infection during pregnancy. The study has many strengths. First, we had a large population-based sample. Second, we further stratified by race ethnicity, which allowed us to provide a more detailed description of who's being most affected by SARS-CoV-2 infection during pregnancy. And third, by conducting multivariate analyses, we were able to look at the independent association between race ethnicity and risk of COVID during pregnancy. And finally, we defined race using a sociopolitical framework and not a biological one that reifies race alone as a risk factor for illness and obfuscates the true culprit of racial and ethnic inequities, systemic racism. There are, however, some notable limitations to this work. First, to identify pregnant people with COVID-19, we relied on linkages of lab-confirmed SARS-CoV-2 case data to provisional birth certificates for completed pregnancies. Therefore, we were unable to identify people with infections who experienced early pregnancy losses or terminations, people who might have had SARS-CoV-2 infection during pregnancy but were not tested, and people who were tested outside of their pregnancy window. Second, we were unable to ascertain probable cases of COVID-19, which may result in underreporting of SARS-CoV-2 infections among pregnant people, especially with increasing availability of at-home rapid antigen testing, for which a reporting mechanism is often lacking. And third, while we aim to capture as many data linkages as possible between lab-confirmed SARS-CoV-2 case data and data from birth certificates by developing a robust linkage algorithm, the linkage process might not have accurately captured the entire population of people with COVID during pregnancy. Fourth, data from provisional birth certificates have more missing data compared to finalized records. However, all the variables we included had less than 12% of values missing. Fifth, the results of this study predate widespread vaccination eligibility and dominance of the Delta variant, thus these results might have been different under these conditions. Sixth, we present data from just one state, so generalizability is limited. And finally, we were not able to explore several structural factors contributing to the observed racial and ethnic inequities such as discrimination, healthcare access, occupation, income, and wealth inequality, and housing, which drive differential risk of COVID-19 in communities of color. We see clear public health implications that stem from this work. First, our results describing the characteristics associated with COVID infection during pregnancy can inform culturally competent public health messaging and outreach materials for pregnant people, such as materials that are inclusive of all education levels and translated into multiple languages. We also contend that this study should be conducted again in the future to examine the effect of the changing landscape of vaccination availability and shifting disease dynamics on the risk of SARS-CoV-2 infection during pregnancy. Future research should also investigate the socially mediated factors such as discrimination, occupation, income, and wealth inequality, and housing that drive differential risk of COVID-19. But finally, the unequal impact of COVID-19 on racially and ethnically minoritized pregnant people deserves urgent public health attention. Even before the COVID-19 pandemic, non-Hispanic Black mothers in the U.S. were 3 times more likely to die from pregnancy-related causes compared to non-Hispanic white mothers. The COVID-19 pandemic may further exacerbate these inequities in maternal morbidity and mortality. I'll conclude by acknowledging Katie Brown, who is our state epidemiologist, for providing crucial COVID-19 laboratory data. Our COVID-19 pregnancy surveillance team, comprised of Masa Yazdi and Irini Nestoridi from our Center for Birth Defects Research and Prevention, and Susan Manning, who is our CDC Maternal and Child Health Epidemiology assignee, and of course our amazing team of medical record abstractors. And as a final disclaimer, the findings and conclusions presented here are those of the authors and do not necessarily represent the views of the Centers for Disease Control and Prevention. Thanks so much for your attention.